Good evening, sir. So we can start the debriefing session. Almost all the students have joined us, more or less. They will join us eventually. So you can start.
Okay.
Thank you. The debriefing session, day one, will be taken by Dr. Nikhilesh Jain, sir. Thank you, sir. Over to you.
Okay.
And it
Just
is going to be a very interactive session. All the students are requested to kindly interact. And any question, any doubt, please leave it in the chat box.
okay. I had done four of these students. The rest of them would be new to me. So probably going a fast rehash also would be done. Uh, this was the case scenario. I think everybody, I mean, the four people who are with me know about it. The other people can read it up. 42-year-old male, history of heavy alcohol use, presented with severe epigastric pain radiating to the back, vomiting and abdominal distension. Baseline examination, patient had tachycardia, BP of 86 by 54, tachypnea, respiratory rate of 28 per minute, and SpO2 of 90% on room air. Temperature was 38.2 degrees centigrade. On abdominal examination, there was tenderness in the epigastrium with guarding and decreased bowel sounds. Lab findings were suggestive of elevated serum amylase, 980, about 9 times more than normal. Serum lipase, 1200 units per liter, at least 3 times more than normal. CRP of 220 milligrams per liter, which is again elevated. Creatinine 2.1 milligram per deciliter, again elevated. Hematocrit of 48% as hemo concentration, and arterial lactates, which are elevated of 3.8 millimole per liter. We did a CT abdomen after 48 hours. Necrotizing pancreatitis was demonstrated, involving more than 30% of the gland, with peripancreatic fluid collections and no evidence of gas. The patient is admitted to ICU for hemodynamic instability and organ dysfunction. Everybody has gone through the vignette. Okay, let me see the. You can reply in the chat. Has everybody gone through the vignette? Okay, I get the first yes. Okay. So I'll move on to the next slide. Here, what clinical and biochemical criteria confirm the diagnosis of acute pancreatitis? Can I have answers in this? Just that, or you need something called as any two of three. So basically, you have to talk about, when we talk about any two of three, you have to talk about abdominal pain, and they do not refer to epigastric or periumbilical abdominal pain or anything specific. You have to talk about the biochemical elevation of enzymes, amylase and lipase, at least 2 to 3 times of normal. And if it is a diabetic patient, then probably more than 5 times of normal. And on top of it, you have to discuss imaging findings, at least sonography, which tells you that there is evidence of pancreatitis there. What are the common etiological factors and how should they be evaluated in this case? Now there are 20 participants. So, yeah. So what are the causes that you can talk about?
The hypertriglyceridemia.
So what would be the cutoff for triglyceride for you to label it as a triglyceride related pancreatitis?
Triglyceride level of more than 200.
No, it is more than 1,000 actually. If you wish to label it as a triglyceride related pancreatitis, you need to have levels well in excess of 1,000. Not below that. You cannot label a patient as having a triglyceride related pancreatitis if you have triglyceride levels below that. So remember that. And as I told you, diabetics, the sort of elevation of enzymes that we are looking at is at least 5 to 6 times minimal. The usual criterion talks about 2 to 3 times, but here it is 5 times when it comes to diabetes. And then biliary and non-biliary causes, of course, biliary most common, gallstone, and the rest of the causes, of course, with reference to this vignette, it would be alcohol, and then there would be plethora of causes that you can discuss. It could be drug-induced, it could be trauma-related, it could be viral infections, so many things that can come into this place. How would you stratify the severity of pancreatitis at baseline? See, there are various scores.
Yes,
You should be well conversant with those scores.
So Bishop scoring system, which includes the blood urea nitrogen.
Bishop score stands for five variables.
Yes.
Then you have
Along with
Apache 2,
pleural
then you
effusion.
have Ranson Imri, then you have a city severity index, and of course you have certain other scores, namely Marshall is also there for defining MODS, right? And when we talk in terms of defining severity of pancreatitis, what all are the ones which actually address that issue? All of them. All of them. The next question would be tricky in the sense of which scoring systems your patient is getting admitted to the ICU. So, which scoring systems are actually applicable in ICU to assess the prognosis in these patients? So, first was severity, but how do you use these scores for prognosis purposes?
So Bishop scoring system is one prognostic scoring system, along with and in that the pleural effusion plays a main role because it indicates a third spacing of the patient.
What other scores do come into picture?
It's based on CT severity index.
We are talking about assessment of prognosis here. Apache 2 is correct. Apache 2 is another one of those scores. And of course, as she told, Bishop score is another one of them. These are the two most common scores when we talk in terms of prognostifying a patient or, looking at a patient in prognostic terms. When should imaging be performed and what findings are suggestive of necrosis?
So imaging is performed at the end of first week. A plain CT abdomen will be useful to
Does
assess.
everyone agree with that?
Yes,
Who all are there for first week at
we
the end of
agree.
first?
1 week.
So basically, when we talk about imaging, we should understand that when it comes to imaging, we are talking about, see, there are three new guidelines that have come up in 2024 and 2025. Totally three guidelines have come up. And now what is accepted is that if the patient is not improving within 48 to 72 hours, it is better to get an imaging done in the form of a CT or MRI at the earliest. Most of the times it would be a contrast CT. However, whenever we talk in terms of contrast CT, sometimes these patients may be having AKI. People may have reservations, even though AKI is not a straight or clear-cut contraindication for doing a contrast CT. Those are the patients where if the patient is hemodynamically stable, you can wait a minute, just so what is happening is that whenever you talk of MRI is done where you feel that the perceived risk to kidney is far more higher. One, MRI also performs better when you are thinking in terms of common bile duct pathologies, or thirdly, when there is a pancreatic duct disruption. All of these findings are really good. In case if you want to quantify the degree of necrosis, then again MRI is good, and digital or subtraction CT, if it is available with you, they perform better. Okay. And so remember that, as per the new guidelines, it is 48 to 72 hours. It is no longer about 1 week. So you should remember that. Okay. So this is the next thing. What are the hemodynamic targets in managing severe pancreatitis in ICU?
I would like to target a map of around 60 to 65 mm Hg and adequate fluid resuscitation with with a CVP of around 8 to 12. I will again like to go with a dynamic fluid monitoring technique, pulse pressure variation or a stroke volume variation. So with a stroke volume variation of less than 12 and a pulse volume variation of less than 14, and a urine output of around 0.5 to 1 ml per kg body weight, with heart rate and avoid tachycardia or bradycardia, kind of maintaining a heart rate of around 80 to 90s.
Okay, so this is pretty good general, but when you're answering, probably you should say static and dynamic variables.
Yes.
And you would prefer dynamic, and you should label what is static and what is dynamic. When it comes to that, probably label static such as CVP or lactate, and dynamic ones, then all your SVV and everything comes there.
Yes.
Right?
Yes.
And when you talk, the second part of the question, you compare crystalloids versus colloids in resuscitation, which is preferred and why?
Crystalloids are better than colloids because in these patients they can may have an acute kidney injury. Colloids can worsen acute kidney injury in these patients. So crystalloids are balanced. Initially, a ringer lactate is preferable in pancreatitis. A preferable fluid of choice is ringer lactate.
Why?
Because
Why?
normal saline can again worsen the acute kidney injury because of its hypochloremia. And it's more equal. It is ringer lactate is more of equivalent to plasma osmolarity when compared to normal saline.
Okay, so to answer your question, one, it seems to be immunologically better, as per the new guidelines, and ringer lactate. And secondly, when you're using large volume boluses, what really happens here is that when you are using large volume boluses, again, it depends on the stage of acute pancreatitis that you are finding your patient in.
Yes.
What happens if the patient has already come to you with creatinine of 2.1, like in this case? So probably whatever the window for giving this patient certain fluids has already gone through.
Yes, sir.
So if at this point in time you actually want to give a lot of fluids, you would actually cause more harm than benefit. And what would happen is these patients would land up with volume overload.
Okay, sir.
Okay. So whenever you talk in terms of this thing, so another thing is, of course, normal saline, as you said, hyperchloremic metabolic acidosis in the type of volumes that we would like to use, and it would give rise to a separate acidosis, which can cause complications. So that is why I would not prefer to use normal saline. And probably if when it comes to a choice between normal saline and ringer lactate, I would prefer to use ringer lactate.
Okay.
What about using a balanced fluid? Would you like to use it?
Yes, sir. If possible, and if possible, I would like to use a balanced salt solution.
See, most of the guidelines and most of the literature does not mention a direct use of balanced fluid in acute pancreatitis per se for resuscitation. So you would be better if you stick to ringer lactate.
Ringer lactate. Okay, sir.
Okay. Now, how would you assess fluid responsiveness at the bedside?
So fluid responsive, again, I will like to go ahead with dynamic fluid monitoring technique, pulse velocity time integral VTI with an aortic root VTI if possible, and PLR or an SLR. Pulse pressure variation, stroke volume variation. I can also do PLR technique, which can indicate the fluid responsiveness. IVC diameter is more easier when compared to other things because it does not involve much. So I will like to see IVC distensibility or the collapsibility index in these patients.
Okay, this is a very loaded thing, when it comes to assessment of IVC. What do you think? This would be an ideal patient for doing IVC?
There may not be an appropriate window in these patients because of the pancreatitis, abdominal wall edemas, and other.
Plus, you never know the rate at which they may be breathing, the sort of tachycardia that may be happening.
Yes, sir.
Plus the intrathoracic pressure changes that may be happening, then it becomes difficult. So it is difficult to state that way, right?
Yes, sir.
What are the key steps in managing acute kidney injury secondary to pancreatitis?
So first step will be to avoid an abdominal compartment syndrome in these patients. A lot of fluid, there can be a lot of third spacing in these patients, and very aggressive fluid overload can just cause a third spacing and can lead to abdominal compartment syndrome, which can again
If
lead to
abdominal compartment
injury.
syndrome is happening, what will it do to the kidney?
It decreases the perfusion, decreases the splanchnic perfusion, and further it causes vasoconstriction and decrease blood flow to the kidneys. So that can again lead to
How? What will it compress? It will compress the
it will
renal
compress
vein.
renal arteries, renal vasculature vessels.
Renal vein would be a better answer.
Renal vein, it compress the renal vein. Yes.
Okay. And what are the other key steps?
I will like to avoid any contrasts in these patients. I will like to avoid any drugs that
So
causes
again, it's a
BP.
loaded statement because the next question is going to come on that anyway
Okay.
in the
I would like to
scenario.
avoid any.
So when you talk blanketly about using contrast in acute kidney injury, your answers need to be very carefully driven. See, using minimal volume of contrast and using better contrast because you've got better contrast materials nowadays. So in that case, probably this may not be correct, you know.
Yes.
Okay. So whenever you talk about using contrast with acute kidney injury, there is no straight or clear-cut contraindication right now at this point in time. Okay.
Yes. I will like to avoid drugs, antibiotics, or any drugs that can lead to acute kidney injury in these patients. And
Avoiding nephrotoxins.
nephrotoxic drugs. Yes. Nephrotoxic drugs. These steps in manage acute kidney. Second.
So maintaining perfusion, avoiding nephrotoxic agents, and probably looking for any other insults that might happen.
Hypotension.
Yeah, hypotension comes into maintaining perfusion.
Yes.
Right?
Yes.
How would you manage ARDS secondary to pancreatitis? Will there be any difference in the way you manage it?
No, sir. It's almost similar to the any other ARDS. I will like to go ahead with lung protective ventilation.
What else?
Proning if indicated, if the patient is not improving, a recruitment maneuvers and proning if indicated. And that can.
Archana, it's like the rest of the class has become silent. Is everybody there?
Yes.
Tarana is there, who has answered. Steny is there. And Karthik is also there. Right? Karthik was the one who I taught yesterday one-to-one. Okay.
Yes, sir. I'm here.
Yeah. So how do you manage? Why don't you take turns, Baba? Everybody has to answer. How do you manage ARDS secondary to pancreatitis? Any major change? Just tell me that. I mean, I just need to, the basics of it, you would be knowing your tidal volume, your low tidal volume strategy, your driving pressure strategy, maintaining the PEEP, avoiding barotrauma, and probably avoiding volume overload. All these things you would be knowing about. Any specifics?
There can be pleural left-sided pleural effusions.
And how would that impact it? Can your proning be impacted?
It can be. It is useful, sir.
No, it is useful. I'm not saying it is not useful. For a ARDS secondary to pancreatitis, can proning be a problem? Potentially.
Yes.
It can be a problem because of
Yes, sir.
abdominal compartment syndrome, probably because of high. Can't think of anything else.
Okay. So we go on to the next slide, the next set of questions. So I've slightly changed track here. So what do you think is the KDIGO score for this particular patient, and how would you stage AKI for this patient?
Is it, more than 1.5, 1.5 to 3. So the patient comes in stage 2 of KDIGO classification.
Okay.
Stage.
How would you think? Would you like to do some sort of this thing, other imaging in this? How many of you are familiar with RRI?
Renal resistive index can be used, sir. Any
And how would it help you?
Sir, any renal resistive index of more than 0.8 indicates more than 0.8 indicates there is an worsening acute kidney injury.
Okay. And when would you think of initiating renal replacement therapy for this particular patient?
So worsening, but any absolute indications like worsening metabolic acidosis, any hyperkalemia, and oliguria of urine output of less than 15 ml for more than 12 hours, or anuric for more than 6 hours. Anything that fits in the KDIGO classification of class 3 to 4, I will like to consider for renal replacement therapy.
Now, assuming you're not able to remove fluid from a patient who's already bloated and volume logged, you already discussed ACS.
Okay.
So, would you like to initiate RRT for that particular patient?
Yes, sir. We can still go ahead with RRT to just remove the acidotic component. Metabolic acidosis can be just corrected without removing the fluids. So that we can just do an without an ultrafiltration, we can go with an just correction of a metabolic acidosis itself can improve a patient to some extent.
How about doing scuff?
Yes, yes. Slow efficacy ultrafiltration.
And what do you think? What mode of renal replacement therapy would be preferable?
I will like to go with the SLED, slow efficacy renal dialysis in these patients.
This patient had a systolic BP of around 85, 86 at baseline.
CRRT
Continuous
is
renal
preferable.
replacement, CRRT.
Continuous-
Okay. So good to hear another voice as well now. So CRRT, when you want to do, how would you like to proceed about it? You would continue with CRRT, or would you like to change over at some point in time? Or would you think of doing a hybrid sort of a strategy?
So initially, I will start with a CRRT, continuous renal replacement therapy with hemodiafiltration.
And why would you want a hemodiafiltration here?
Because again, there is it is going to be a slow process to some extent. I will have to remove the third spacing fluid also. So just a plain dialysis may not be useful. So I may have to remove to some extent a little amount of fluid.
Right.
I would prefer hemofiltration in these patients because from what you are seeing, the creatinine levels are not too high, and
Right.
you don't need very rapid removal of creatinine. So hemofiltration will be preferable in this patient because it will also take care of both of fluid removal and then slow
Okay.
removal of creatinine or the toxins.
Fine. The next question is regarding a troubleshooting question. I would be doing certain slides at the end specifically for that, but anybody is free to answer this. Supposing you do CRRT for this patient and your transmembrane pressures go up, what happens?
I will think of the filter clogging initially. So I will see if the filter has been clogged. And if it is very early, I can increase the pre-dilutional fluid, and so that the filter doesn't clog and it can function for some time. If still it is not working out, I may have to change the filter, CRRT filter. Initially, I will try with increasing the pre-dilutional fluid so that any clogging is washed out. If not, I may have to change the filter.
Okay. So we are back to that question. What if you wish to do a contrast CT at this time? What do you think would be features of contrast-induced AKI?
Any new onset acute kidney injury, like increase in creatinine or a decrease in urine output after doing a contrast, like within 48 hours of after 48 hours of doing a contrast, is the definition for a contrast induced acute kidney injury.
And how would you prevent it?
Hydration is the proven benefit, has a proven benefit to prevent contrast-induced acute kidney injury.
Would you give a long trial of hydration for this particular patient?
No, sir, just a short trial of hydration, that is 24 hours or 6 to 8 hours before contrast has been injected. Before a contrast CT. And other proven things can be N-acetylcysteine can be used. Initially, we can go with an 1.2 gram IV stat followed by 600 tablet or oral medication of 600 BD for 1 or 2 days to prevent the contrast induced. Other unproven benefits are sodium bicarbonate are not proven. So the proven benefits are from hydration and N-acetylcysteine.
Okay. Among N-acetylcysteine and hydration, which carries stronger evidence?
Hydration, sir.
Okay. Now, is prophylactic renal replacement therapy indicated once you've done the procedure? And what does current evidence suggest regarding high volume hemofiltration for prevention of contrast-induced injury, AKI?
There is no evidence. The evidence does not show any benefit of high volume hemofiltration, sir.
Right. Now, during intermittent hemodialysis, if you are going to do intermittent hemodialysis, hypotension and ultrafiltration failure occur. How would you adjust your UF goals, dialysate sodium, and temperature to manage this?
Not sure, sir.
Ultrafiltration and continue
This is free. Anybody
hemodialysis.
can answer. No problem. Any other answers?
We can decrease ultrafiltration goals.
Okay,
Or stop
that is one.
ultrafiltration.
That is one. What else?
Old dialysate and the high sodium dialysate.
Can you be slightly louder or clearer? Adding D5.
And we will use cold dialysate, do it, and we will increase sodium in the dialysate.
Okay. Any other answers? This is fine. I mean, this is correct.
You increase the dialysate sodium.
That seems simple. So I'll come to that in the end again. So I'm leaving it for now. Now, when should nutritional support be initiated in severe pancreatitis? This is severe pancreatitis, mind you.
As soon as possible.
Any other answers? Or anybody begs to differ?
When we can start with an enteral nutrition, a small volume enteral nutrition in the beginning. And we can, if the patient is tolerating, like if there is no abdominal pain or any abdominal distension and there are bowel movements, we can continue with small volume enteral nutrition. So, a tropical feed is also advisable. That is a low carbohydrate diet with a small volume diet is advisable in severe pancreatitis.
This I have to see. Anyway, this I have not read, so this I have to see. And how would you compare enteral versus parenteral nutrition? This is simple, which is preferred and why?
Enteral nutrition is preferred than parenteral because it maintains the entry gut, the bowel integrity it maintains, and the gut flora can be maintained with enteral nutrition.
What are the indications for jejunal feeding in acute pancreatitis? And can you achieve it? How do you achieve it practically?
We can place the rice tube beyond the gastric lumen. We can just pass the rice tube beyond the gastric lumen and we can place it distally, or a jejunal tube can be placed.
That is, you mean a feeding jejunostomy, right?
Feeding jejunostomy.
Okay. What are the goals of caloric and protein intake in a critically ill patient with pancreatitis?
20-25 kilocalorie per kilo.
Okay.
Protein 1.02 gram per kilo.
That is fine. That's simple. So this is good. This is correct only. How would you monitor the tolerance and complications of enteral feeding?
After
I'll-
each,
Yeah, go ahead. Anybody? Open for anybody.
The first thing, you can use a gastric ultrasound to monitor residual gastric volume. Otherwise, you could okay, I think that's one practical method that can be used to monitor.
Basically, you are looking at
Sort of-
GRVs, right? Gastric residual volumes.
Yeah.
And complications of enteral feeding, if there are any, because of intolerance.
Because
aspiration.
decreased bowel motility, there can be abdominal distensions, which can increase the distension, which can increase abdominal compartment syndrome again.
Okay. Now, I think Tarana spoke about aspiration, right?
Yes, aspiration.
Okay, but in realistically, no, Tarana, I mean, there's no heightened risk of aspiration. What really happens is, in fact, even in a normal course of patient stay, there are 40 to 45% patients who do aspirate, despite the fact that we may consider their cough reflexes to be normal. So aspiration does happen even otherwise, but there is no heightened risk of aspiration because of enteral feeding. And for that matter, you may be surprised to know that there may be certain people who may be advocating 45-degree position for giving feeds and all those things. Even that doesn't work out that well. Doesn't matter. Even if they are lying down on their back, that's okay. It doesn't give rise to a more than higher risk of aspiration. So I'll go on to the next one. Okay, what are the local complications of severe pancreatitis?
Necrotic pancreatitis, which can set in at the end of around 7 to 10 days. Any pseudocyst collections, pseudocyst and necrotic pancreatitis.
Would you get pseudocyst so fast if it's a...
No, it is after at least 4 weeks of pancreatitis. Necrotic
So
pancreatitis is
what else in local complications?
infected necrosis, collections around the pancreas, infected collections.
Right.
Ascites.
Can you get venous thrombosis or venous thrombi?
Yes, sir.
Splenic
It can
thrombosis.
also go into like splenic thrombosis can also happen.
Can these patients develop GI bleeds?
Because of DIC, they can.
Not because of DIC.
Portal vein thrombosis.
No, portal vein and splenic vein thrombosis we discussed. Sometimes it tends to erode into the gastroduodenal artery, and that becomes a problem.
Okay. Okay.
Okay.
Yes.
And how do you recognize that the pancreatic necrosis is infected?
Persisting fever spikes, we can aspirate the fluid collection.
How feasible is it? That is the next question. But how feasible is FNA for taking out the collection and gram stain or culture? And again, if you are going to mention that, I'm going to cover both these questions in one shot. If you're going to cover fine needle aspiration, do remember that there's no consensus on when do you time it, how do you time it, and what are the type of patients that benefit most from your fine needle aspiration. And subjecting that fluid to again gram stain or culture, which can be an optional methodology. If the patient has a concurrent blood culture which is positive for an infection, then do you treat it or not? Or do you assume the patient to be infected or not? What do you say?
If the patient continues to be symptomatic, like a persistent fever spikes or an abdominal pain, we may have to consider treating it. So persisting fever spikes and high counts, a high procalcitonin or we have to consider treating it. So
Okay.
if the patient is clinically stabilized and he is, if it is not causing any symptoms, if the patient is asymptomatic of the collection, we can leave it.
So if you were, I'm just, slightly going back a bit. If you were to just identify two parameters based on which you would actually define a patient's propensity to go into AKI.
Okay.
Just two parameters. So what would you be targeting at? I'm just asking about two lab parameters. That's it. Which are simple and which are probably done everywhere.
CRP.
With interleukin 6 and
No, nothing so complicated. I'm sorry.
CRP level.
No, not CRP. It is basically hematocrit and BUN.
okay.
Both of them you need to monitor, and do remember that if they are already elevated by the time the patient comes to you, like this patient did, then you've already missed the bus. So what all your therapeutic interventions happen, they are aimed at actually keeping them under control or keeping them sort of normal, right?
So just a doubt. Initially, these patients will have a high hematocrit rate, sir. So do we keep a high suspicion of AK or when the hematocrit matters?
See, it's both. Actually, previously, among the previous guidelines, it was blood urea nitrogen alone, which had a higher weightage in terms of a variable which needs to be monitored. But now, the current 2025 one, there's a recent statement that has come in. In that, they've also included hematocrit in that. So, I'm talking about hematocrit as well, because you would be taking the exam based on current things.
Yes.
So, previously, yes, BUN was absolute. If your BUN was high, then there was a problem. You hydrate the patient more and more. If your BUN was not high, it was normal. You keep the hydration to the tune of 50 to 75 ml per hour max to max.
Okay.
That's how it used to be. Because you do not know at what spectrum you are catching this particular patient and how much hydration has already been given to this patient, or there's no assessment of how much dehydrated this patient is. So that becomes a problem. And if you resuscitate them more, what really is happening here that they will go into volume overload.
Okay.
Right. Now, what systemic complications commonly occur and how do they influence prognosis? Sorry, I skipped one question. Sorry. Discuss the management of abdominal compartment syndrome in pancreatitis.
Management is decreasing the abdominal wall edema, probably with diuresis if the urine output is low, and again with to some extent with diuresis we can see if the abdominal edema is coming down, and improving the bowel motility. So by improving the bowel motility, we can decrease the bowel edema, bowel movements, and improve the bowel movements and decrease the compartment syndrome.
What else? Anything else?
You have to pass an NGT, nasogastric tube, to drain the intestinal contents.
A flat test tube also along with it is needed.
There's no evidence for putting in a flattest tube, please.
Okay, sir, sorry.
So never mention a flattest tube, just for decreasing abdominal compartment syndrome.
Okay, sir.
So that is there. And another thing that can be done is assuming that if it is not recovering well and if you're not able to remove fluid, probably if you just want to do a short
surgical
session.
decompression.
Yeah, surgical decompression is one. Another thing would be scuff. Maybe just subject the patient to a single session of scuff, remove some fluid out of it, and that's it.
Yes.
Right?
Yes.
Okay. And how does this influence prognosis? Systemic complications, how do they influence prognosis?
It can lead to, because of multi-organ dysfunction, these patients, the prognosis becomes bad.
Any other things to add in this? Okay. Outline the management of ARDS in the context of multi-organ dysfunction due to pancreatitis. Again, the same things, I mean. So this is part of that thing only. We've discussed this before earlier in the presentation, that what all you need to do in terms of managing your ARDS. So that's it. I'm going to skip this. Okay. What are these questions? What are the indications for intervention or drainage in pancreatic necrosis?
When we suspect it is an infected infected necrotic pancreatitis connection, we have to.
Fine, that is one. What else? Assuming if a patient is having acute and chronic pancreatitis and they have developed a cyst or something. Would you like to drain it?
No, sir, we can wait with an antibiotic coverage.
Of course.
Okay. Now, when it comes to, I mean, I have not taken that question about whether you should give antibiotics in acute pancreatitis or not. But why that question becomes very important when we talk about pancreatic necrosis? Can anybody tell me?
Because the necrotic segment could become secondarily infected. So at that point,
so what will happen if you're giving
in time,
antibiotics?
antibiotics must be introduced.
So what is recommended, as per last guidelines on this year's as well, that at times when you feel that you want to do surgical intervention, but you want to delay it, that is necrosectomy, that can be delayed further, right? So those are the patients in which you can give antibiotics even up to a duration of 30 days, 30. And with after giving antibiotics for that much duration, what really happens is what you get off is a walled off pancreatic necrosis. So if the pancreatic necrosis gets walled off, managing it becomes relatively easier from a surgical point of view. Right? So what are the different, and again, when we talk about antibiotics, again, deviating slightly away from the topic, whether should we give antibiotics in acute pancreatitis or not? See, before 2006, everybody said prophylactic antibiotics needs to be given. After 2006, there were 5 different statements, and they all said that no, giving antibiotics does not help. And there's still a Japanese guideline which talks about it. Now, what really happens is none of us will subject all our patients to FNAC for the simple reason that, as I discussed before, there is no consensus. When to do it, what is the point in time to do it, and how significant it is in terms of establishing infection when you've got an imaging as well. See, if you see gas on imaging, then it is an indirect evidence of infection. So what really happens is that most of the times that the patient worsens, people tend to give antibiotics to cover it. And they just document the necrosis part of it. Right? Am I clear?
Yes,
Everybody
sir.
Okay, okay. Now, what are the differences between percutaneous, endoscopic, and surgical approaches?
Yeah, the surgical approach is more invasive and mortality is very high.
Correct.
So the endoscopic technique is preferred to drain these collections.
Okay. And what is the step-up approach?
It's an endoscopic approach.
Correct. You initially do an endoscopic approach, wait for some time, and then then do a surgical approach or a necrosectomy later on. There's one trial that all of you should know in that regard, that is PANTA trial. Everybody would talk about it as far as acute pancreatitis goes, right? And then what are the specific surgical indications in acute pancreatitis?
Just drainage of the pseudocysts into the peritoneal cavity, connecting a shunt between the cyst and the...
So see, cholecystectomy is one thing, definitely yes. Okay. Then these patients can develop vascular complications. Again, that of which of that might require a surgery. What happens if it develops a collection, if the patient develops a perforation peritonitis, or if the patient develops a abdominal compartment syndrome, which is not responsive to your conventional measures? All of these become surgical indications in a patient of acute pancreatitis. Okay. How does the timing and type of intervention will influence morbidity and mortality? So it's obvious if you're going to do a surgical intervention early in the course of the disease, it is more difficult. Tissues are edematous, chances of death or mortality are higher. So that is why we have approach called the step-up approach, wherein you try to initially opt for a percutaneous approach. If doesn't work, do an endoscopic approach. If still doesn't work, then you go for a surgical approach. right? So this was just an image of, all of you know about this, right? By now, all of you would have been knowing about this. Can somebody tell me what is this?
It's abdominal pressure.
Bladder pressure.
Device.
Bladder pressure.
Correct. It's a bladder pressure monitoring device, and not a bladder pressure. Basically, we are trying to
Abdominal.
perform a test for measuring intra-abdominal pressure by a police catheter-based device. There's a CRRT machine, and these are certain images that I put. But beyond the images, what I will do is I am going to share with you certain things about troubleshooting, which may be of help to you as far as exam goes. So this is about access-related transmembrane pressures. Okay. These are the possible causes. Access transmembrane pressure exceeding the safe limit. Effluent rate is too high, too much plasma is being removed, that is one cause. And plasma filter pressure drop is increasing, possibly due to insufficient anticoagulation. This is what happens. Actions would be you decrease the replacement fluid or increase the blood flow rate. Return to your alarm screen, press your continue switch, or you can decrease the blood flow rate and or adjust the anticoagulation prescription. Okay. And this is other way of doing it, wherein the transmembrane pressure exceeds the membrane pressure limit. Ultrafiltration rate is too high, too much fluid is being removed, and wrong measurement of filter and effluent pressure. So again, troubleshooting would be you decrease the PVP replacement and or patient fluid removal rates, or alternatively, you can increase the blood flow rate. Return to the alarm screen, press continue. Okay. If the axis is extremely negative, what is happening here? Patient is moving, coughing, or being suctioned. Even then, access pressures can be extremely negative. Or if it is the line that gets clamped, kinged, or partially blocked, or if the catheter is clotted or out of position in vein, or blood flow rate is too high for the access device. And of course, the last thing is your pressure sensor has failed. So actions that you need to do, wait 15 seconds for self-clearing attempt, then press continue. Clear and then press continue. You can flush or reposition the access catheter. Use the access sample site to infuse saline to release negative pressure or lower the blood flow rate. Press continue. And of course, if pressure sensor fails, end the treatment, call the service. Access is extremely positive. External device, if it is in use, is delivering blood at a very high pressure, or blood flow rate has been set very low as per the blood pressure delivered by the device. And of course, last of them as all is pressure sensor fails. So actions would be you decrease the delivery pressure of the device, you increase your blood flow rates, return to alarm screen and press continue, and treatment and call service. Air in blood, possible causes, disconnected line, leaking connections, set not fully primed, return line not installed in air detector, or of course air or foam in the tubing. For blood leak, air bubble in effluent line at the level of blood leak detector. Effluent line is not properly installed in blood leak detector. Otherwise, there can be a liquid or debris in tubing path through the detector, and of course, there can be a leak in filter membrane. So this is what you need to do. And okay, this is just a comparison. All of you would be knowing about this, but this may be handy for you. I do not know. Maybe if because the session is getting recorded, I'm not aware whether it's getting recorded or not. Then you can probably access this later on whenever you want. This is just a brief snippet of various forms of renal replacement therapies. May be of use to you in terms of remembering things if you want to do it very quickly. Okay. And this is what we wanted to say, If there is hypotension during the therapy, causes can be excessive ultrafiltration, osmotic shifts, patient has sepsis and low preload. You stop the ultrafiltration temporarily, give 100 to 200 mils of NS bolus if hypovolemic, decrease your blood dialysate or replacement flow rates, support with vasopressors if needed SOS. If it is persistent, then you can switch from SLED to CRRT or decrease the duration of renal replacement therapy. Okay. These are the type of
About temperature, sir.
Hello? You said something, I think.
Temperature adjustment, is it affecting hypotension?
Wait a minute. I just went back to the slide.
Temperature adjustment, it affect hypotension?
What absorption?
Temperature.
Can you put it in the chat? I'm unable to get it, I think. I just opened the chat. Yeah, true. Temperature adjustment. Yeah, that was also part of the question. Temperature adjustment would also reduce your hypotension. Okay. And this is what? This is again just a small, sort of a vignette for understanding what happens. This is sort of a quick rehash for your exams. Okay. And these are the various alarms. Again, same thing as a repetition. High prearterial, low arterial pressure or a high negative pressure. That is the inflow obstruction. Check for King's, catheter position, clotted tip, low blood pump speed. Remedy would be check your lines, reposition, flush if persistent, you change the catheter. If there's a high post-venous pressure, you look for outflow obstructions. Check for clamp, tubing King, insufficient drainage into venous limb. And remedy-wise, you change the patient position, check your return line, and consider a clot which needs to be cleaned. Then high transmembrane pressure, filter clogging, decrease your UF, change your filter, and consider a review of your anticoagulation. Okay. So that's it.
Can I get the first slide, please? First vignette.
Can I get it? What you're saying?
First slide, please. The
First
vignette,
slide.
Well, because I
First.
didn't attend vignette.
Okay. Just a minute. I'll give you the first slide. So this was the case vignette. This is what you wanted?
Yes. Thank you. Much appreciated. Thank you. Okay, I screened it. Okay, thank you.
Okay. So that brings today's session to an end. I hope it was good for you and I hope it was enlightening for you. Right?
Thank you, sir.
Okay. Thank you and wishing everyone a very good night and best of luck for your exams.